fact that we do this, regardless of what the rationale is. If we take up the let's say we switch our model to the model that you propose, is the fact that we prescribe these drugs going to be any different based on this change in rationale?
Yeah, no, you're right. Very good point. And for example, benzodiazepines, which in what I'm suggesting are considered to be anxiolytics, to be specific treatments for anxiety, are used widely in all sorts of situations, including in people with psychosis or any sort of disturbance in institutions widely. And in that situation, they're understood to be working according to a drug-centered model. I mean, they're sedatives and restraints. So there are lots of circumstances when people are using things openly, not necessarily interpreting it as treating a disease. The facts, I think, are different with different situations. So the reason that drugs are used for people in institutions, for people who are very disturbed, is because it's very difficult to look after people in that situation, because people are very distressed in that situation, because various drugs can help to dampen and suppress symptoms and therefore help people to improve and help people to be more manageable. In someone with depression, what is the fact of the matter? I was at a meeting of general practitioners recently where it was a meeting about dependence on prescribed medication, such as benzodiazepines and SSRIs. And the reaction of general practitioners is, why are you giving us such a hard time? At least we're not prescribing barbiturates anymore, which were highly toxic. We've got to have something to give to people. So, I think the fact is, when we're treating depression, very often we're treating a perceived need for some sort of quick chemical fix. Or we might be responding to our own sort of distress or helplessness in that situation. So I think it depends on the situation as to what the fact of the matter is. But I think you're right, yeah.
One of the effects or the consequences of what you're talking about seems to me, in a way, is the potential for a more collaborative or more honest conversation. I mean, I spent the first 6 years of my career working in a private psychiatric hospital, and so I feel like I sort of saw everything in one way or another. They used to line up 15 to 30 people for ECT every Wednesday afternoon. But one of the, if we're not sort of suggesting that there are specific, that we're creating a new balance in the body, but instead simply describing, here are the potential benefits and here are the potential consequences, the patient has the opportunity to make a more informed choice. And I've certainly known plenty of people who were very much helped in terms of bringing some sense of order to their lives from a medication, even though they would also say it's terrible to feel small, it's terrible to feel impotent, it's terrible to feel so tired, but it's also nice to not be completely out of control and, so.
Yeah, yes, absolutely. I think you made the point really well. I think it enables a more collaborative discussion about what drugs might and might not be able to achieve. So, they're not going to make everything right. They're not going to necessarily make you feel great. But they may be able to do this. They may be able to just calm you down that you can put your life in order a little bit, as you say. So as I said, I think, the basis is describing and having lots of information about what sort of effects drugs might be able to have. But as well as, we do also need to think also about the consequences, about the fact that once people get on drugs, it's difficult to get off them. They often end up on them long term. Then if they want to come off, they might have difficulties. There are all sorts of considerations to be addressed in that conversation. But I agree, it should be a conversation and not as it is at the moment. You see, I mean, I know what many of my colleagues would say to me. Well, of course we do have conversations with patients, but the implicit structuring of that conversation at the moment is: you have an illness, I've diagnosed your illness, and this is the treatment for that illness. You can choose not to take it as long as you're not under the Mental Health Act, but that's the situation. Whereas, as you point out, it's a very different sort of structured conversation if you take a drug-centered approach.
I just had another comment from sitting in the back of the room. There are 23 psychiatrists in this institution. And in the morning, we'd have the morning report, and we'd hear about the new admissions from the day before. And over time, I became aware that I could predict the diagnosis based not on the symptoms that were described, but on the personality of the psychiatrist who had admitted the patient. And I mean, with great accuracy.
You mentioned that it was with, or you appreciated that Eli Lilly, I think it was, published that study, even though that it showed things that didn't look so great. My concern is that there's a lot of research that happens that doesn't get published. Is there any way to get access to some of this research that shows maybe the drugs aren't as beneficial as they get purported to be?
That's a really good point. There's a psychiatrist and journalist in the UK called Ben Goldacre who's campaigning to try and get trials published, because not only information on adverse effects, but information on efficacy could be suppressed. So if you do a number of trials, one of them comes out positive, 3 come out negative, you just publish the positive one. That has happened a lot, we know that. So there's a campaign to get trial results published, but there's still plenty of other research that might not be published. There's an example is one of there's been a study. There've been a number of studies of trying to prevent the onset of psychosis in people with these non-specific early signs by treating them with antipsychotics. Started off by this group in Australia that I mentioned. One of those studies has happened in Germany, and they published some preliminary findings in 2007 and haven't published anything since. It must be negative, I would assume, because it's such a big area at the moment. It would have been big news if they'd wanted to publish it. So we know that we know that stuff isn't being published.
Hi, I'm proud to say I'm a psychiatrist. I hope I'm not drawn and quartered as I leave the room later. Could you clarify a statement you made about, I think you kind of said all of these medications are addictive, psychotropic medications, and my read on it is the benzodiazepines are, the barbiturates are, but I don't know of literature that suggests the SSRIs are, or the atypical or typical antipsychotics.
Well, it depends how you define addictive. That's the answer. I mean, all these drugs have a withdrawal syndrome when you stop them. There are effects, noticeable effects when you stop them. So if you stop an antipsychotic, you get insomnia and agitation and vomiting. If you stop an SSRI, there's a very prominent withdrawal syndrome. There have been large campaigns by service users in the United Kingdom, by people who've experienced these withdrawal symptoms, to get them recognised. So if you define dependence or addiction as the body becoming tolerant to something and then noticing when it's withdrawn, which it seems to me is the purest, clearest way of defining that, they are all addictive. They're not all nice. People don't crave or don't go and seek SSRIs and antipsychotics in the same way that people do seek out some people do seek out benzodiazepines and barbiturates. So that's the difference. It is the quality of the altered state and the fact that for those drugs it's nice and people go seeking them. But it seems to me that's not a necessary part of how we define addiction or dependence. The actual physical bit is the body getting used to a substance, and that applies with everything.
I think
Oh, yeah, there's a debate. There's certainly a debate about the nature of addiction and the meaning of addiction.
Yeah, that I would, my own clinical practice, I'd say not everyone that I've seen, most people I've seen abruptly stopping a antipsychotic goes into a withdrawal, and the same with the SSRIs. Some do, some don't. Prozac, fluoxetine, which is a very long half-life, it'd be very rare that someone would have a discontinuation syndrome. Then Paxil, on the other hand, very common. So.
Yes. But I mean, that's the same for everything, isn't it? You know, I mean, that to me shows that they are addictive in the same way that the ones with the short half-life, you get a withdrawal syndrome with it. Clozapine, you get obvious withdrawal symptoms. Longer-acting drugs, you don't.
Hi. At what point do you think that we should accept responsibility in us, like as individuals? I mean, you go to the doctor, they give you all these sort of treatments that you can take. They try to explain it to you. And I agree that sometimes pharmaceutical ads may be misleading, but the risks and what this drug does and the side effects, they're always at the bottom. They may be little, but they're still listed. So don't you think us as individuals, we need to start showing some sort of responsibility when taking these drugs? And if we feel that it may not be the best treatment, then maybe seek other medical advice or maybe continue talking to your doctor, because as you said, a lot of these disorders can be treated without the use of drugs.
Yes, I think that's a really good point. People have always sought out chemical fixes. I was reading a book by Elizabeth Gaskell, who was a contemporary of Dickens recently, and the father in that, who's a working-class factory hand in Manchester, is addicted to opium. And it's made quite clear in that book that, you know, this is what gets him through the day in a miserable and very difficult and exploitative environment. So people have always turned to drugs to block things out and blank things out, and people have always looked for a quick fix as well throughout history. So that is one of the reasons why we have as much prescription drug use as we do. And to that extent, people need to take responsibility for it and look for alternatives. But I think there are a lot of people, for example, that go to the doctor undecided because they're not quite sure where else to go. And if the doctor was able to say to them, you don't have to take this, or, you know, said there are alternatives that, you know, some people would take antidepressants in your situation, but there are these other things to try. If that was said more often, I think that fewer people would take up the option. I do think that the saturation of our society with this message that depression, distress, however you wanted to call it, is a medical disorder, is a chemical imbalance and needs drugs to be rectified, does influence people.
We have a question from the Bideford campus, from Glenn Stevenson of the psychology department. Thank you for the talk. I generally agree with many of your premises and conclusions. What are your thoughts on recent evidence indicating prefrontal cortex alterations in first episode schizophrenics, primarily gamma band oscillations and suggested deregulated GABA, glutamate circuitry that could, in part, relate to the cognitive dysfunction seen in schizophrenics? Do you believe a drug that might regulate this circuitry, like a glutamate modulator, might have some therapeutic utility for a subset of schizophrenic symptoms?
Well, glutamate is one of the most recently fashionable suggested chemical causes of schizophrenia, or some of its symptoms. And I haven't gone into the literature on glutamate in as much detail as I've gone into it with dopamine, but I'm not convinced that it will stand the test of time. What else is there to say about cognitive function and schizophrenia? It's very complicated. It's very complicated doing the research on it. People with